Good afternoon, ladies and gentlemen. Welcome to today's webinar. I would like to remind you that this conference is being recorded. At this time, all participants are in a listen-only mode. For those connected by telephone requiring operator assistance during the call, please press *0. Web participants requiring support should use the chat feature on your screen. I would now like to turn the conference over to your moderator, Jennifer Thornhill-Verma, Senior Director at the Canadian Foundation for Healthcare Improvement. Please go ahead.
Thanks so much, and thanks everybody for joining us on the Priority Health Innovation Challenge webinar series call. As usual, we do want to start by acknowledging that we're meeting on land that has been inhabited by Indigenous people since the beginning. And in particular, we acknowledge that we're broadcasting this webinar from Ottawa, which is the traditional non-ceded territory of the Algonquin Nation. We recognize, we deeply appreciate their historic connection to this place and the opportunity to gather here today, and in fact, to gather across the country. The focus of today's webinar is innovations in mental health care. And we hope that this will be a useful webinar for not only those who are working in the stream of mental health and addiction services as part of the Priority Health Innovation Challenge, but also those working in the stream of home and community care. And we say that because we know there are a lot of common principles and transferable ideas. We've seen that in terms of the teams that are participating in this innovation challenge. A few items of housekeeping before we get started. If you haven't already done so, I've seen many of you already do this. Thank you so much. Introduce yourselves in the chat box. If you have any questions off the top or you want to share anything off the top, feel free as well. I will be monitoring the chat box throughout the call, and I'll help to facilitate conversation with our speakers and one another. We are offering simultaneous interpretation and a fully bilingual chat box for this webinar as well. So we do go through and share feedback. If something is shared en français, we share it in English and vice versa. And at any time throughout the webinar, if you do have questions in either language, please feel free to share them. We do reserve time for Q&A, but we also try to address them as we go. This is me. Thanks for having me. I do want to introduce my colleagues. So we have our Senior Improvement Lead for the Priority Health Innovation Challenge and also the Momentum Challenges, Lindsay Yarrow. Lindsay's joining us from Kingston today. Sabrina Khan is an improvement lead with the same challenges, and she's out east in St. John's, Newfoundland and Labrador. So thanks, ladies, as ever, for joining us. We also have a couple of speakers who've joined us today. So Sam Marwan is a strategic healthcare professional with deep operational experience, a track record of leading transformative and, in fact, award-winning clinical care innovation, specifically integrated care models in the mental health and addictions sector. So thank you so much for joining us, and she's joining us from Toronto. And then here in studio, we have Effie Hellis. She's a Knowledge Mobilization Officer at the Canadian Agency of Drugs, Technology and Health, CADTH, and she works with researchers and stakeholders in improving the understanding of the evidence on a variety of topics. She also supports evidence-informed decision-making in different areas of healthcare, including mental health, of course, which we're going to chat about today. In terms of our objectives, we do want to take a look at where we're at in the Priority Health Innovation Challenge journey. Many of you I see on the line are participating either as a partner, so thank you to our partners for joining us today. I see the Mental Health Commission at Mantler. I see Canadian Medical Association, Jennifer Kitts, just as an example, but there's many more of you on the line. Thank you so much. We also want to hear a patient impact story about the innovative work carried out by one particular Priority Health Innovation team that has positively impacted the patient journey, so we're going to start with that. We want to understand some of the current challenges in the mental health and addictions sector. Sam is going to walk us through that in particular. And we also want to learn more about some innovative improvement ideas in this space. Of course, it won't be everything, but we're going to shine a light on collaborative care and internet-based cognitive behavioral therapy. In terms of our journey so far, so those of you who've participated from the outset, we have set before us an over-year journey that started back in April when some of you would have registered. The whole intention of the Priority Health Innovation Challenge is to highlight innovation that's happening across the country. So we know there are known sore spots and weaknesses in access, for example, in mental health and addiction services. The focus of the Priority Health Innovation Challenge was to say, if this is the problem, how are we addressing it across the country? What you're looking at is our journey insofar as the programming of the Priority Health Innovation Challenge, and we've actually almost reached the midway point so far. We do have an upcoming challenge called, naturally, the Midterm Challenge Award, and that's going to be due January 17th, so mark your calendars for teams participating. And this challenge remains open, so if you're just joining the call today and you're interested in participating, this challenge remains open for recruitment. So we started recruiting back in April, but we continue to recruit teams into the Priority Health Innovation Challenge. Lindsay's going to talk more specifically about the challenge, so stay tuned, you'll hear more about that. I do want to welcome some of our new teams who have joined. So we have 3 new teams that have joined, the Canadian Mental Health Association Bounce Back Initiative. We also have the AIDS Network and Kootenay Outreach and Support Society. And we also have a team that's joined from the Department of National Defense. So thanks so much. You can find out more about the team certainly on our website. We're actually compiling as teams join abstracts that give you a flavor for what each of the teams are focusing on. Each team does select a priority indicator that they're going to be reporting on based on outcome, and they also share reach of their patient or client population. So you can learn more about these teams on our website. And I'm going to turn to Lindsay. Check, check. Lindsay, you there?
Can you hear me now?
We can hear you now. Over to you.
Oh, wonderful. I think there might have just been a delay there. Thanks. So as you know, the Priority Health Innovation Challenge began in April of this year. And on behalf of the project team, it's really been a privilege to hear about the wonderful work that the teams are doing out in the community and the impact this has had on the communities, the patients, and the families. So this was the time that we thought we'd like to check in with you and hear some of those stories and share them with the group. So today we wanted to share a story from CHEO and Carly Brown. Many of you may have seen on previous webinars. Carly unfortunately was unable to join us today, so she asked me to share the story, and I'm happy to do that. So I'm just going to jump right into it. So on behalf of Carly, imagine spending the first years of your child's life in and out of hospital. 153 days in hospital to be exact. This is the everyday reality of one of our little 2-year-old tracheostomy ventilated kiddos who's had 19 admissions over the last year to CHEO, ranging from anywhere from 6 days to 3 weeks. That's almost an admission every 2 weeks. This child has the most loving, capable parents, yet still requires frequent hospitalizations due to frequent respiratory infections, inadequate secretion management, and respiratory exacerbations. So this is a really good example of an experience that drove system change. Because I think we would all agree, for the 2-year-old child and their family, that's not care closest to home, and to be that age, likely with siblings in and out of hospital, is quite significant. So from the CFHI funding, because CHEO has won a number of awards so far, they've been able to fund a community respiratory therapy specialist, and that's Carly. She was added to the child's care team, whereby she attended pre-discharge meetings, developed a chest action care plan, obtained specialty equipment for him prior to the discharge home, and Carly's given some examples here of what that is, but really trying to manage those symptoms and support his family. Trained his home nursing staff on cough assist, and actions that should take the patient should the patient show signs of deterioration, and to manage more comfortably, competently, and safely at home. The community specialist has been able to act as a resource for the family, provide ongoing and home-based follow-up, so care really where the family is and where they're looking for care. So Carly wanted to share with us that due to their initiative, their innovation, so prior to this, the child had 153 hospital days, and after the intervention, he's been in hospital only 2 days. So that's an incredible, incredible change, and certainly I think a success that many of your teams have seen in terms of the impact of your innovation and how this is really changing that patient care journey. And we're hopeful in this case and in many other cases, that this change starts other changes that continue to improve that system of care. So kudos to the CHEO team. Thank you for sharing. And if you're one of our Priority Health teams and you have a story you'd like to share, please reach out to us because we'd love to give you the opportunity to highlight that as well. Back to you, Jen.
Fabulous. Thanks so much. And I think we're going to go straight to Saima, actually, to talk about mental health collaborative care. Saima.
Great. Thank you. I hope you can hear me okay. So I'm actually right now, oh, perfect. So I'm actually in Boston right now. I moved here to work at Dana-Farber Cancer Center. However, I have 13 years of mental health experience, and I'm really looking forward to this webinar to bring me back to my Canadian roots. I'll start with the polling questions just to get a good understanding of our participants. And I'll read through the questions if you could please submit your answers. So the first one being, what clinical setting do you currently work in? Second one being, are you familiar with the collaborative care model for primary care and mental health? Do you currently work in an integrated clinical team? And do you have access to mental health specialists for consultations in your setting? And as I go through the presentation, you'll get a better idea of why setting the stage for this question was important.
I think, Saima, that might be what we're going to see by way of results there. I used to work in radio, and every time there's silence, I think, what's happening? What's going wrong? But we're still here, guys.
Okay.
Great. So we just closed the poll. So back to you, Saima.
Okay, thank you. I'm waiting for the connection to start again. Okay, so I'm sure this group, the participants, we're quite aware of the struggle of mental illness from a health system perspective in terms of treatment and ensuring the continuum of care. But what I've done is for this presentation, I've really looked at some of the current information that's out there, and I have references at the bottom, so feel free to actually connect directly with these reports if you do require more information. So based on the recent Center for Addiction and Mental Health 2019 report, Mental Illness and Addictions, Facts and Statistics, we're at 6.7 million people struggling with mental illness, and that being the leading cause of disability and having an economic burden of $51 billion a year. 4,000 Canadians die by suicide every year. Mood disorders are definitely at much higher risk of developing long-term medical issues. Nothing has changed in the context of people with mental illness being twice as likely to have substance use disorders, specifically being alcohol as one of the main ones. And of course, people with mental illness and addiction still are more likely to die prematurely than the general population. I think when I was looking at the different papers and found the latest information, things have gotten worse in terms of where we are right now. And the key items that stick out, which I've presented in this slide, is to really highlight where the gaps are from the information that I found from the Canadian Medical Association and the Canadian Psychiatric Association, and then hopefully the examples that I have in terms of clinical practices for collaborative care and how they can actually address some of the things that we have pointed out in the current states and the gaps. So patients are seeking services for physical health do have a better access and a funding model for evidence-based treatment. There's still a big gap in accessing evidence-based practice. There's a lack of universal coverage for medication, which I know hopefully with the new government's priorities that would be looked into. There's also an aging healthcare workforce, especially in the rural areas, where the gap for
looking at mental health resources is going to get worse because there's a large population of specialists that will be aging out of the healthcare system. Access to, of course, publicly funded psychotherapy across the country, and then, of course, wait times and stigma. The other report that I would really like to highlight is the new CHI report from 2019, and that one was very, very good in clarifying where most patients are getting their care, and most patients are still, they're feeling comfortable within their primary care setting, where 80% of the patients with common mental health problems usually go to the family physician for these services. And the primary care settings are also already include a team model where they have integrated treatments, and it has been proven in these settings, and because the access is already there, primary care services are still geographically more available than tertiary care and mental health specialists, specifically in rural areas. And this report actually is great to illustrate the visuals and the statuses of supply of healthcare professionals and the challenges that that we currently face. So what is a collaborative care model? And I think a lot of us have heard a number of different definitions for collaborative care, integrated care. And I think one definition that I like is from Dr. Nick Cates from his paper in 2018, and it's referenced on the slide, that collaborative care is used as an overarching term to really describe the processes of primary care and mental health providers sharing resources, expertise, knowledge, and decision-making. And what I'll do is I'll definitely be giving you examples of these models and what are the core components that make up a collaborative care. And I'm sure based on your clinical practice, you already have either some of the components or all of the components. So we'll get right into it. So most commonly used components is the screening and diagnosis of both mental health and physical health, assessing baseline to understand where the patient is, and then providing the appropriate supports and self-management tools, and then of course ensuring that there's clinical support and supervision for interventions for both mental health and physical. So bringing these things more in a collaborative manner, so that patients are not being treated in silos for various diagnoses. And the best opportunity, what we've seen in literature, is primary care settings. Core principles based on AIM Center at the University of Washington. So if you just Google AIM Center and University of Washington, you'll find tons of resources on the collaborative care models, and the key core principles being patient-centered care, evidence, measurement-based care, population-based care, and accountability. So with these principles, going back to the gaps that I identified from our previous reports, it is clear that having a collaborative care model primarily in the primary care setting will ensure that we have improved access by primary care being the first point of contact. There's a better early diagnosis opportunity rather than have a wait time for a tertiary care center, early intervention for especially patients being able to start treatment sooner and have a step care approach, and of course looking at building clinical capacity, going back to one of my main concerns that we have of an aging workforce, especially in the rural areas. So, so again, all of this is based on the principles that are shared health priorities from the Government of Canada, and I'm not going to go over this because I just wanted to bring this up as a reference. And this slide basically goes into the best practices that I've talked about for collaborative care and how they meet the highlighted gaps in mental health. So again, access to mental health specialists. A collaborative care model is known to bring the clinical capacity or at least team members in the primary care setting for better access and sooner access to care. We talked about wait times for access and treatment, and a collaborative care model has, and a step care approach has been looked at in a number of cases as being the best way to decrease wait time for access and treatment, because majority of the patients can have an initial treatment start earlier before they need that tertiary care center treatment. or a referral for consultation for something more complicated. And then, of course, cultural safety is a highlighted gap in the mental health area, ensuring that the model of care developed has components of cultural safety and implementation techniques to ensure appropriate treatment for all Indigenous and marginalized populations, as we see that there is definitely a gap in care and evidence treatment for these groups. So really quickly, based on a lot of literature, here are the components that are necessary for a successful implementation of any kind of collaborative care approach. You have the people side, the principles, process of care, practice, and proven interventions. And going through them, people basically means engagement and a dedicated primary care team or champions within the primary care sector, nurse practitioners. Having a consulting psychiatrist or a mental health specialist within the team has been very beneficial in a lot of models. And of course, having patient and family caregiver feedback and participation and leadership throughout this process has shown a lot of improvement in developing these collaborative care models. Principles to drive collaborative care, there's the teamwork, the communication, the processes, external stakeholders such as partnerships with mental health specialists if you don't have them embedded in your team, having standardized care such as using measurement-based care such as using PHQ-9 to develop your baseline, and of course cultural safety principles, which more and more literature is coming out in terms of how to embed that in care. Processes of care. So what are the changes that the team needs to move towards a collaborative care model? A good capacity building assessment of the team in terms of comfort and training requirements, and also standardization that is required from current state to future state. Extremely important. Processes are definitely something that are the most time-consuming when embedding a collaborative care initiative. Practice, there are a lot of treatment protocols out there, a lot of guidelines, and really looking at them for best practice in mental health and addictions and bringing them to practice by developing a protocol or embedding it in the electronic medical record has been quite promising based on the different projects and models that are out there at the moment. And finally, proven interventions. This is definitely an area that could use more evidence-based treatment, assessment, treatment, and follow-up and transition. And there are a lot of algorithms that are already available. This is a good segue to the next speaker as well, who will be talking about the cognitive behavior therapy and the innovations in that area. And then finally, a successful model. I wanted to highlight the impact study, and the papers that are listed for the impact study are at the bottom. Impact study was done in 1999 to 2001, and it was basically the foundation of a lot of things that we see when we think about any kind of integration or collaborative care. So anytime you, like even the HQ quality standards in Ontario that is asking for doing the PHQ-9 regularly was based on the impact study illustrating that it improves care by measuring baseline and then throughout the treatment. So this is a good little slide that provides overview of the components, such as using a registry for tracking of the patients, evidence-based guidelines, and then of course the stepped care model that keeps being brought up, where you need to understand the different acuity and ways to treat them and when to actually transition the patient to tertiary care, but mainly catching a lot of this at the right point in time rather than having wait times for that initial assessment. And this slide illustrates how the principles or the core components merged with the impact study. So the people, these were the people involved. There was a care manager, primary care provider, psychiatrist, principles that standardize assessments and guidelines, and then of course timing of when to follow algorithms, processes of care. Everyone was co-located in the clinic with very key weekly consultation practice. This was a randomized controlled trial research, so a lot of the processes were quite strict, but they could be loosely modeled in a clinical setting rather than research. And of course, the proven interventions that were tried out, tested, and of course illustrated that they brought out better clinical patient outcomes than treatment as usual. And sorry if I had to rush there a bit, but there was a lot of information. So I'm going to actually go back to our end of the presentation polling questions. And I'm just waiting for the screens to be updated. So now, based on the information shared, are you currently a member of an interprofessional team within your clinical setting? Second question, does your clinical setting practice standardized care based on what I mentioned of various assessments and protocols and algorithms? Third question, does your current clinical setting have enough capacity to treat patients with mental health disorders in terms of the interventions being right there and then within your clinical setting, or do you have to send your patients externally? Fourth question, does your clinical setting have a stepped care approach to treatment for mental health disorders? And then finally, does your clinical setting have access to psychotherapy interventions for mental health disorders? I know in my past experience, the access has been limited and wait times have been disastrous in terms of starting the patient on one intervention and not having the other one available for about a year's wait time, depending on where you are. So just to get an idea if your clinical setting has access to psychotherapy interventions for mental health disorders.
Fabulous. Thanks, Emma. I did summarize earlier in the chat some of the results from the earlier poll. We'll do the same with this one. It looks like we're reaching sort of capacity. Now, I know not everyone on the line will be able to answer this, given you might be calling from a partner organization supporting Priority Health Innovation Challenge, but these are great questions that align with the evidence that Seema just shared. So we'll take a screenshot of this and, again, summarize it in the chat for you so you have that information. And when you do get a recording of the call, you'll certainly be able to see these questions as well if you want to use this with your broader health team. If you do have questions for us today, don't hesitate to share those in the chat. We're going to come back and address those. But for now, I'm actually going to turn. We're going to close the poll. It looks like we've evened out in terms of our responses. Closing the poll, and we're going to revisit the slide deck. And as I mentioned earlier, I'm pleased to be joined in office by our colleague from CADIS, Effie, so we're going to pass the mic over to her.
Thank you very much, Jennifer, and thank you very much for the invitation to share our work on the evidence for internet-delivered cognitive behavioral therapy for major depression and anxiety disorders. So for the next few minutes, we will just provide a very brief overview of the key findings of two evidence reviews on internet-delivered cognitive behavioral therapy, or ICBT, for the treatment of major depression and anxiety disorders. And that will include some information on the implementation considerations for ICBT in Canada. I have some extra slides for you in case you need to access them after the webinar with some extra information on implementation. So the evidence reviews that I will be covering today are based on two health technology assessment reports done collaboratively by CADIS, the Canadian Agency for Drugs and Technologies in Health, and Health Quality Ontario. And I am here representing two very large teams that worked on these reviews for a number of months last year. So the reports were published in March of 2019. So just a very brief overview of the two organizations that I'm representing the work today. So CADIS, for those of you who are not familiar with our work, is an independent, arm's-length, not-for-profit organization responsible for providing Canada's healthcare decision makers with objective evidence about the optimal use of drugs and medical devices, basically everything that's used in healthcare. We are funded by Health Canada and the provincial and territorial ministries of health, except for Ontario and Quebec. And we do receive application fees for the three programs that are shown on this slide. Once our work is complete, you can find all of our reports and a range of products that we have on our webpage at cadis.ca. Health Quality Ontario, I believe now is part of Ontario Health due to some recent changes in Ontario. It's sort of the equivalent of CADIS, but for Ontario only. So they produce health technology assessment and they make recommendations to the ministry in Ontario about which health services should be publicly funded. Again, the reports and the funding recommendations are publicly available on their website at www.hqontario.ca, and anyone in Ontario can submit a topic to be considered for a funding recommendation. So let's get back to the evidence. As I said, the findings that I will be presenting are based on two large reports that were done by the two organizations, and you can find the full reports on the organization's websites. And for CADEF, you can find both reports if you go to cadef.ca/ICBT. So I'll start with a very brief description of CBT. I'm sure most of you are familiar with. So for major depression and anxiety disorders, we do know that CBT is an effective evidence-based psychotherapy, psychological treatment, and it's the most commonly used psychological treatment for these disorders. As you may know, the way it works, the patient meets with a therapist over a series of sessions, face-to-face interaction, and they work together to identify unhelpful patterns of thinking, attitudes, beliefs, and behaviors, and they work together to establish a set of strategies and skills, or a toolkit, if you like, to change those unhelpful patterns of behavior and thinking. Now, when we talk about internet-delivered cognitive behavioral therapy, ICBT, as you may imagine from the title, this is CBT that's delivered over the internet. So in this case, the patient does not have to go to the therapist's office. CBT is delivered through an online platform, but the user has to have a computer, smartphone, or tablet with an internet connection. So ICBT programs usually include a series of structured modules with very clearly defined goals, and the users are asked to complete a series of readings and activities over a certain amount of time, and that's part of the program. So ICBT may offer ways for some patients to overcome barriers to effective therapy and accessing this therapy. For example, for patients who live in remote or rural areas with limited access, patients who may be concerned with stigma, or in other cases, the condition that they have may not allow them to be easy for them to come out of the house and go visit a therapist. There are two main modalities for ICBT. So we have what we call the unguided ICBT, so that's more self-directed and there is no therapist involved, and the guided ICBT. So a therapist is available for the user, and the user connects with the therapist at certain times, at certain points in time during the program. So why do we do the evidence review? So we do know that in Canada there is a wide variety of ICBT programs currently, but we also know that the effectiveness of ICBT is not well established. We do know that the ICBT is not currently funded in a systematic way in Canada. There are no policies around it, and there are no concrete frameworks for implementation and integration of ICBT into the clinical pathway for clinical practice, and this is not established. So the HTA work meant to mainly inform policy decisions around the optimal use for ICBT for the treatment of depression and anxiety disorders. So we wanted to establish, are we okay with the slides?
Yes, sure.
Yes.
Great.
Yeah, so that was the policy question that we set. And next slide, please. So for the HTA, we did a comprehensive review of the evidence on the following aspects of ICBT. So looking at the evidence for clinical effectiveness, cost effectiveness, looking at patient perspectives and experiences, ethical issues associated with ICBT, as well as implementation issues for having ICBT as an option for treatment. And this evidence was reviewed and discussed by the two expert committees associated with the two organizations. So for CADEF, we have the Health Technology Expert Review Panel, or HTEP, and Health Quality Ontario has the Ontario Health Technology Advisory Committee, or OTAC. They deliberated and they provided recommendations at the end of these reviews, which I will present in a few slides. So let's see what the evidence looked like. So we're going to start with a clinical review, and again, it's very high-level information for the key messages, no details about limitations or methods. So the key message from the clinical review is that ICBT seems to be more effective than the waiting list control, which is receiving ICBT at a later date. And it is effective for reducing symptoms of mild to moderate major depression and select anxiety disorders, and also effective for improving quality of life for individuals with these conditions. There was increased certainty in the evidence for guided ICBT compared with unguided ICBT. So guided ICBT, again, is ICBT with the support of a therapist. And unfortunately, there was not sufficient evidence for us to be able to make a statement for comparing ICBT with face-to-face CBT, either individual face-to-face or group face-to-face ICBT. In terms of economic analysis, costs that are associated with ICBT were included in the models, which did an analysis from the perspective of the Ontario Ministry of Health, and CADES adapted that model to reflect the pan-Canadian context. So again, the key message from the analysis is that guided ICBT, when compared with alternatives, such as usual care, face-to-face CBT, and unguided ICBT for the short-term management of mild to moderate major depression or anxiety disorders, may be a cost-effective strategy if one's willingness to pay threshold is between the numbers that are shown on this slide for each of these conditions.
And I should mention, I think this is a conversation that's come up in the chat around the cost. Mm-hmm. We had a helpful comment from Rachel from Alberta Health Services, so I'll just maybe mention it now, saying cost-wise it is variable. There are a couple of apps, applications with cognitive behavioral therapy elements that are free, but they aren't really modular, like the ones described in the report that CADES and H2O did. And there are a number of evidence-based modular ICBT mental health apps, but they can be quite expensive, upwards of $200 per patient. So if others have comments on this and you're using ICBT, we benefit from your experience. But I just wanted to pause here for a moment because it was in direct comment to the questions that have been asked around costs.
Good comment, in reality, for sure. Okay, so moving on to the patient's perspectives and experiences, we did find that overall ICBT is very well accepted by users because they do appreciate the flexibility and the control that they have over the location of therapy, the time and the pace of therapy. However, having said that, we also identified variable experiences, and even for those who like ICBT, there's variation in experiences and preferences, so a tailored approach in terms of content, level of support, and monitoring may be considered to reflect the patient's individual learning style, priorities, and needs. And such tailoring may be better supported if a therapist is involved, such as in guided ICBT. So basically, it is well accepted, but a one-size solution doesn't fit all. It's not for everyone. It has to be the right match for the individual. For the ethical analysis, as you may imagine, given the online environment of providing this treatment, issues that came up as concerns were issues around data security, privacy, and confidentiality. Also, the ability to establish that effective alliance, that effective relationship between the therapist and the client, given that different environment and context of having this treatment. And to alleviate these concerns, having transparency in communicating those risks and the differences between face-to-face and ICBT, and having mechanisms in place to mitigate those risks are important in this case. And finally, for the implementation issues, we do hear that a lot of jurisdictions and a lot of groups across the country are interested in adopting ICBT, but we also know, as I mentioned earlier, that there is no national framework, strategy, policy around it for implementation and funding. And we also know that some programs are available, but they are available only within one province and not across the country. So we did a review of implementation issues. We looked at barriers and facilitators at the different levels of decision-making. So a few examples here, when it comes to clinicians, for example, lack of awareness and training on ICBT. In some cases, negative approaches and attitudes towards ICBT were identified as barriers. When it comes to healthcare organizations, the costs for establishing the necessary infrastructure for having ICBT were also barriers. And on the other hand, if we do have a national strategy that provides a structure and parameters for policy, quality standards, and regulation that may help, as well as having strategies in place that will frame how ICBT can be incorporated into the clinical care pathway, such as stepped care approach, or having it as a complement to face-to-face treatment that may also facilitate implementation.
And I'll just mention, because again, this aligns with the conversation that continued, and it's so helpful. One of the parts of the webinar that we find is most beneficial is connecting folks. So Doreen, for example, from the Ottawa Hospital Mobile Crisis Team, following on the conversation about cost, had said that, you know, one of the potential barriers for her client population is that clients don't have the financial capability. So if it's not accommodated in the system, you know, and this is a patient out-of-pocket service, cost can certainly be a barrier as well. So she suggested online self-help, and then we hear again from Rachel from Alberta Health Services about a free app, Anxiety Canada Mind Shift Cognitive Behavioral Therapy. So thank you once again for sharing that helpful information.
Thank you, yeah. So a little relevant, I guess, to these comments are that HQO, after they looked at the evidence, they recommended publicly funded guided ICBT for these conditions in Ontario. And the CADES Expert Committee recommends guided internet-delivered cognitive behavioral therapy to be offered to adults with these conditions. So there is support based on the evidence for guided ICBT. So ICBT with the support of a therapist based on the evidence that was available. So very quickly, we did review implementation considerations, as I said, but we did collect a number of programs that are available in Canada, and I am including those here for you in case you need to explore further. So these are programs available in Canada, and we also identified programs that are available internationally, and we may have access to them from here in Canada. So just for your information. And the following slides, and Jennifer, if you don't mind going through them quickly, I just included the slides for your information. These are slides that we show information from our implementation issues review at the different levels of decision making. So if you want to go back to them and see the barriers and the facilitators that we identified in our review. And I'm going to be finishing soon here. I just wanted to draw your attention to a national event that we held a couple of weeks ago where we had the opportunity to present the evidence findings, but also involve a number of stakeholders in this field. So we heard from a representative of the Ontario Ministry of Health, clinicians, and also an ICBT user who described her journey with mental health, looking for support and using ICBT, and what she found helpful and not helpful. So I encourage you to check the video. It is on our page, cadex.ca/ICBT, and it's just the first part of the presentation. So I thought it was very powerful. So if you want to check that out, that would be great. And we do continue our KM and implementation support work on this topic. And our aims are to increase awareness of the effectiveness and the evidence on ICBT, identify work that's happening across the country, support implementation, and facilitate collaborations between groups with varying levels of experience with ICBT. So we do encourage questions, we do encourage connections. So if you want to connect with us, we'll be happy to work together and identify ways that we could support with the evidence component, the work that you are doing. We have a few resources on our page, some summary tools and brokering some information. And we do have liaison officers across the country, so I see a lot of people from across the country, so I encourage you to connect with the liaison officer in your area to discuss any further needs and information you may need on the topic.
And I know that a couple of our Priority Health Innovation Challenge teams actually work directly with CADES program advisors and support officers throughout the country, so we're grateful. I'm sure they're grateful for that support, and we are as well.
We look forward to continuing the work on this topic for sure, so it would be great to do more specific work on more specific needs as they come up from people across the country. And just a quick note to end this, that we are continuing our evidence work on ICBT, this time for post-traumatic stress disorder, and the report and recommendations will be available early January, so keep an eye out on our site for that. And I'll end here. Thank you very much.
Thank you so much for that wealth of information. So again, you'll have an opportunity to have these slides. You'll see the deeper dive that we didn't get into in detail, but you have some additional information there. But resources, contact points, a patient story of what the experience has been, and also a commitment of more information to come soon in the new year. So happy holidays. Of course, you can connect with CADIS and Health Quality Ontario, which I believe now is part of the Quality Business Unit of Ontario Health. So those resources remain available and through the connection points that Effie mentioned, but that may change, I'm sure, in the upcoming months under the transformation that's happening underway in Ontario in terms of how to access it. But sign up for CADIS e-alerts and find out more about their work on their website in the meantime. So we were able to address the questions that had come in through the chat box. You'll see, too, that we've now summarized the results from both of the polls that Simon had shared in both English and French, so take a look at that. Again, these were helpful, I think, particularly for some context setting and really thinking about the application of the evidence that Simon had shared to your setting. And she's sharing here now that based on the outcomes of the survey, one area to start would be to develop processes around a stepped care approach, as only a quarter of survey participants, and this is a small sample size, so we'll keep that in mind, but a quarter of participants currently have that, and that's one area that locally we do have more autonomy and ability. I know the Mental Health Commission, who's on the line, has produced and shared a tremendous amount of valuable resources, particularly related to stepped care, so perhaps we could work with our colleagues at the Mental Health Commission as well to make sure we circulate information related to that. I'm going to turn back to Lindsay, and actually we're going to share some updates related to recent Mini Challenge Award recipients and talk to you more about the upcoming Priority Health Innovation Challenge Midterm Award that's coming up January 17th. Lindsay.
Great, thanks, Jen, and please continue to keep the chat going in the chat box if you have any questions as we move through the remaining part of the presentation. So in terms of our mini challenge number one, this is along the course of Priority Health, along our journey, we have award opportunities for teams who are registered. So we had these teams won $10,000 in our most recent award opportunity, and I think you heard earlier how CHIO is using that to support some staffing, but would like to recognize CDI Home Health, and they're working on caregiver distress. Lanark Renfrew Health and Community Services is working on supporting clients with COPD and receiving care at home. We've got Joseph Brandt with the FACT program, and they're looking at urgent mental health and addiction support in the community. Vancouver Coastal Health is actually implementing ICBT and Health is Key, which as we mentioned earlier. We've also got service navigation happening at Alberta Health Services. And case collaboration used through a case collaborative model at Calgary Foothills. The CHIO team, as we heard earlier, is helping pediatric ventilated patients. We have McGill University Health Center, who's supporting palliation. And again, Alberta Health Services Home Living, who is helping individuals stay at home. So some really incredible work happening there, and some great access to awards to continue doing the wonderful work that's happening. In terms of the next steps at Priority Health, if you're registered, the next award opportunity is January 17th. If you're not registered, as Jen said, a great encouragement to reach out to us so we can support you with completing that process. For teams who are registered, please submit your data. The Midterm Challenge Award is based on the data you've submitted. So there's some pretty substantial awards, $20,000 for first place. And second place, $20,000 for first place, and second and third place are both $15,000, and that's for each of the categories. And you'll see we pay down a number of places. So if you're having any challenges or you haven't submitted data yet, please reach out to us so we can assist you with that. This is an outcomes-based challenge, so it's important that we have that data. That's one of the ways that you demonstrate that you're moving the dial on that indicator you selected. So we do that through collecting data through our portal once you've registered. So again, please register and reach out to us so that we can assist you with getting that data in. And at our next webinar, we'll be sharing the winners of that. So we're really interested in hearing more about what you need. We have 3 planned webinars as part of the Priority Health Challenge between January and October when the challenge ends. So for those 3 scheduled webinars, we'd really like to hear what is of interest to you. So I think the production team will be putting up a whiteboard, and given the time, what I'm going to do is I'm going to hand it back to Jen to facilitate a bit of a question and answer. But as we're doing that, just really interested in hearing from the teams and those of you joining us on the line of what might be of interest to you to hear about in those upcoming 3 webinars so that we can tailor the content to your needs.
Thanks so much, Lindsay. So we did have a preemptive response from our colleague Scott Robertson. Hi, Scott. He said he'd be interested in presentations from teams that have implemented or are implementing stepped care or other team-based interventions for depression in their primary care settings. Sama agrees that's a great idea. In the meantime, she does have access to some literature that can illustrate examples of stepped care approaches. And she's happy to send them. Absolutely, Sam. And if you, we could connect you directly. If there's also a way that we can circulate a summary to those who've joined us today, we'd love to do that. Other topics that you may be interested in, we're keen to hear. We're of course reaching out to all of the Priority Health Innovation Challenge teams, but these webinars, we remain open. So we do often have participants, certainly from the partnership. There's 19 supporting organizations that have come together to support the Priority Health Innovation Challenge. And so you see some of those organizations represented on today's call, including CADEX, for example, who kindly participated, but the Mental Health Commission, Canadian Medical Association, Asita New Brunswick, Nursing Homes Association is on the call as well. So we have a range of partners that we work with. So if it's not something that we're prepared to speak to, we certainly within our roster of partners can organize for the upcoming 3 sessions and calls. Okay, Sabrina's clarifying too, we're not actually going to do the whiteboard, but we're happy to hear your ideas either through this venue or otherwise. I think we addressed most of the questions. If you do have any others currently for Sama or Effie while they're here, please feel free. But we will be sending you out some additional information so from today's webinar, so you have access to that. And this will be available on demand, so you can certainly play back and share with colleagues. We encourage you to do that. We'd appreciate it. I'm going to move us to our close, but don't hesitate if you do have questions or comments. Our next webinar is actually scheduled March 17th, and it's at noon, so same time as today, noon Eastern time. I want to give a special thanks to our presenters who joined us for today's call and sharing that wealth of information. As ever, I want to thank the partners who support the Priority Health Innovation Challenge teams and the teams themselves. Lindsay, Sabrina, thank you so much for all the work that you're doing that makes this webinar a success. And also there's a bunch of people that you don't hear from or see during the course of a webinar who I can see behind the screen today. They're in the booth and producing, so thank you, ladies. We encourage your feedback and insights. We are going to, I think, close with a feedback poll. So this is where you get to tell us what worked well and even better if. Don't be shy. So take a few minutes to fill that out. It's certainly helpful as we plan ahead for future webinar content, upcoming awards as part of the Priority Health Innovation Challenge. We're going to leave this open for a moment here. Sabrina's mentioning too, if you have any questions specifically about the Priority Health Innovation Challenge, you're interested in joining, seeing this as an opportunity for you, you've got the email inbox there. That's going to link you directly to Sabrina and Lindsay actually. All right, we'll keep that poll open a little while longer, but I do want to close the call otherwise and end the webinar portion. But thanks everybody. Appreciate your joining. Have a great holidays. I hope you get a chance to rest and relax and rejuvenate and all that good stuff. We'll see you in the new year. Goodbye for now.
Thank you for your participation. This concludes today's call. You may now disconnect.